Okay, thank you very much. Let's see if we go to the slides. There we go. Maybe back up two. Okay. So I'm going to talk a little bit about this, but I'm not sure if there is any advantage of going last. One advantage is that many of the things that I could have talked about under this rubric have been said, some of them by me in my questions, so I decided the only thing left was to show some very concrete examples that might inform the conversations that follow. And the two examples I'm going to focus on are the PCORI method standards and also go back to the checklists, actually the same example that Barry Collar brought up yesterday, and introduce some other dimensions to that. So the only thing I'm going to say immediately about preclinical research, and this could be a much longer talk than the 10 minutes we have, is that there's a lot that I've learned in starting to teach some of the clinical lab researchers at Stanford that we assume people understand and are taught, but are not. And I'm just going to assert these. Each one of these has a story behind it, but I'm not going to tell the whole story. I'll tell one mini story. But concepts that are poorly taught or understood by junior, and I will put a question mark, and some senior lab scientists include the basic elements and formal logic and purpose of experimental design. So what is experimental design? It includes things like how many subjects, how many mice, how many cells, how many wells, whether there's any randomization, whether there's any blinding, everything having to do with the plan for the experiment. And this, of course, links. It's a critical link in the chain of inferences. There's very little understanding of the foundations of statistical inference and the meaning of basic statistical summaries. And I mentioned this in one of my comments during the last 2 days, is that the trainees, we did a poll of the courses they were taking, and they were tremendously loaded in the most advanced courses, with very few taking what we would call the introductory courses, which are really the foundational link between hypotheses and data. That they didn't understand, but they did understand neural networks, or at least they said they did. Okay. They don't really understand how there is this link between the question, the design, the measurements, the conduct, the analysis, the inference, the conclusions, and the generalizations. This chain is really not well understood. They get their data, they analyze their data, they want to know what's the right test, which in my lectures I say, if you ever ask what's the right test, you're always asking the wrong question. And I will say that virtually every gap in training or understanding is created or reinforced by the literature they read. And here I'll just tell a very mini story. I wanted to show them bad graphics. So how do you find a bad graphic? Well, you Google bad graphics. It turns out you get them right up. So I found a bad graphic from a scientific journal with showing some bar graphs with error bars with an N of 3. So how can you have a bar graph with error bars based on only 3 measurements? So I thought, well, okay, that's not very fair. I showed them that, and I said, let me look in the literature that they're going to read. And this was around October of last year. So I opened up, I hate to say it, I opened up Science. I opened up the first article, the first figure, and there it was, the line graph with N equals 3 with error bars. Very first one. I didn't have to go past the first article. So there it is, and it wasn't Googling bad graphics. So it's in the literature. It's everywhere in the literature they read, and it's very, very, very hard to train new scientists to say, oh, you need to do something different than what you're reading in an article that gets into Science. So I'm actually going to deviate. I'll come back to that at the very end, but I want to reflect a little on the efforts at PCORI to improve methodology through the development of the method standards, which we aspired to be minimal. So the PCORI's methodology standards are actually required by law. This is why the methodology committee was appointed. It's a unique funding body in that it was, by statute, only created 2 boards, the governing board and the methodology committee. That's pretty unbelievable. I don't know that there's any other science funding body in the world that has those two, just those 2 elements. So the methodology standards are developed by the methodology committee and adopted after public comment. They represent what we hope are minimal standards for design, conduct, analysis, or reporting research, in that everybody would agree that if you didn't fulfill this standard, your research probably was either invalid or close to invalid. We didn't want to have a debate about best practices, which, as you know, are constantly a subject to revision. So they're used to both assess the rigor of the applications, monitor study conduct, and evaluate final research reports. And we have a number of PCORI representatives here who work with these, and hopefully they won't force me to issue a retraction after I say what I say. So these are all listed in the PCORI methodology report. Here are the groups of standards. There's 65 standards grouped into 16 topic areas. The 5 categories on the left apply to all research: how to formulate a research question, patient-centeredness, which is in the name of the institute, data integrity and rigorous analyses, missing data, heterogeneity of treatment effects. That reflects the kind of research we fund. And on the right are standards related to specific designs. And I'll show you an example of some of these standards. And we work moderately hard on these things. And you see the ones that were just introduced in the last few years. The others were introduced right at the outset after about a year of work. So these are the standards for preventing and handling missing data. And there are 4 standards. And I'm actually not showing you all the text. I'm just showing the headings. Missing data 1, describe methods to prevent or monitor missing data. Seems pretty minimal and obvious. Missing data 2. Now, here I'm going to show you a little of the detail. This is the only one I'm going to show you. Use valid statistical methods to deal with missing data that properly account for statistical uncertainty due to missingness. Estimates, I'll just read the highlighted. Methods used for imputing missing data should produce valid confidence intervals and permit unbiased inferences. Single imputation methods such as last observation carried forward, baseline observation carried forward, and mean value imputation are discouraged. Now, I'm going to invite you to think about exactly how you would assess that, either in practice or in advance, are discouraged. MD3, record and purport all reasons for dropouts, et cetera, and examine sensitivity of inferences. I think everybody would agree here that in principle, these are basic principles of how to deal with missing data. Now, I will tell you, in order to actually assess these, either on the front end or the back end, is not easy. But even more important is, how do you assess 65 standards? So this is in the spirit of what Shai Silverberg showed us yesterday with the consort guidelines. This is the spreadsheet that the staff has to use for the input of applications. This is only the first page of 3. If you can't see it, that's the whole point. Let's just keep going. Here you go. Here you go. You need reading glasses and a lot of Tylenol, I think, to measure up an application against 65 standards. Now, not all 65 apply to every application, but I will tell you that these standards are very difficult to apply, in the sense that they require actually a fair amount of sophisticated judgment. And a lot of staff time is taken in trying to assess this. And what's on this spreadsheet is not just yes or no, did you apply them, but where in the application. So you have to point to the point to the page and paragraph in the application where it was addressed. We also do this in interim reports. So after a year, we think that things might be more evident in the progress of the study. And here we have much more general: report how your project meets the methodology standards, and we have just the broad stroke standards for reporting, formulating research questions, patient centers, et cetera, et cetera. So they have to file this as part of a progress report. Well, this was actually evaluated. The other thing that PCORI does, which was mentioned yesterday, is we actually look at the written reports before they are submitted for publication. So we're maybe the only funding agency that does that. And we peer review them, actually, in a pretty rigorous way. So at the Peer Review Congress, a group of investigators, including one member of our methods committee, looked at the final reports to see how they adhered to the method standards. And guess what? Malcolm will not at all be surprised by this, or Brian. 0 of the 31 final reports adhered to all the standards. Now, maybe that's an unfair bar, but it was, disturbing when you look at the detail. Number 4, many reports did not use appropriate methods for handling missing data, even though we had pretty rigorous signposts at the beginning for how to do it. Most reports examined heterogeneity with subgroup analysis, which we specifically prescribed, but few conducted formal tests for heterogeneity, and we could go on from there. But it is clear that the standards by themselves didn't do that much. So what are the implications of this? Even a funder with substantial leverage and resources has difficulty changing dominant paradigms of practice, no less paradigms of reasoning. We're now conducting a portfolio review to see which manuscript problems are detectable or preventable in the initial stages of the proposed research. And we're going to go back, look at the applications, see if we can connect them with the issues we identify at the end. And finally, the difference between technical solutions, the standards, and true policy solutions, getting them used, no less understood, is enormous, and the latter is much more important and much harder than the former. This is a list from Sonias Nature, and this is journal, and this is the checklist they use. I'm not going to go through it, but I will just submit that if you go through each of these, they suffer from some of the same issues that our method standards do. They're very reasonable. They're very good. But to assess whether they're actually followed and to enforce them, very, very difficult. And that's exactly what she said yesterday. Now, the last thing I want to do is actually talk a little bit about checklists. And the only thing I'm going to do here is read a commentary on the interpretation of checklists from Peter Pronovost, who was actually the person who developed them, not the Checklist Manifesto book. And Peter Pronovost developed this checklist originally to reduce central line infections in a very famous project in Michigan that purportedly reduced central line infections to 0 in Michigan hospitals. And this is something he wrote just a few years later with sociologist Charles Bosk. And I will ask you if you find it illuminating. It says, "The Art of Medicine, the Reality Check for Checklists." He said, "The study was widely reported in the popular media and elsewhere as a triumph of a simple checklist as a solution to patient safety problems. Yet the widespread interest in this study is a dual-edged sword. It was a great story. The problem is that the story may well have been oversimplified. The emphasis on checklists is a Hitchcockian MacGuffin, a distraction from the plot that diverts attention from how safer care is really achieved." And I would encourage you, every time it says safer care, let's talk about research quality or research improvement. Just substitute it in, and you'll see an echo of everything we've said in the last 3 days. Widespread deployment of checklists without an appreciation for how or why they work is a potential threat to patient safety and high-quality care. I want you to reflect on that. You're going to see why he says that in the subsequent just 3 more excerpts. The mistake of the simple checklist story is the assumption that a technical solution, checklist, can solve an adaptive sociocultural problem. Emphasizing checklists as the explanatory mechanism for the reduction in catheter-related infections obscures the complex labor necessary to create a collective local faith in the checklist. How support was mobilized for coordinating work around infection control is the real story of the project. And this is maybe the most important section. Another important feature is the emphasis of the model on conferring legitimacy on the intervention. This was achieved by allowing teams to customize the implementation of the evidence locally and challenging assumptions about who has relevant knowledge, who counts as an expert, and who is able to and ought to act to improve safety. And we'll call this research reliability. Think about low-level whistleblowers at Duke, like the medical student who wasn't listened to, right in the middle. Indeed, it would not be a mistake to say there was one keystone checklist. It would be a mistake to say there was one keystone checklist. There was not a uniform instrument, but rather more than 100 versions. How many people here knew that there was 100 different checklists? Nobody. Each ICU, informed by evidence and a prototype, was encouraged to develop their own checklist to fit their unique barriers and culture. Taken together, what the Keystone program did was to change workers' motives for cooperating so they internalized new norms. There's norms. So this was not a story about checklists. It was a story actually almost anti-checklists, as we think of them. So this is his conclusion. When we begin to believe and act on the notion that safety is simple and inexpensive and that all it requires is a checklist, we abandon any serious attempt to achieve safer, higher quality care, quality research. Reporting the Keystone Initiative as a success of checklists teach the wrong lesson, namely that reliable, safe care requires nothing more than insisting on routine, standardized procedures. The simple checklist story in the press created excitement and among the public and policymakers, but the real story of Keystone is messier and more complex. Although we all hope for the simple solution that with ease and no additional expense, it makes the stay in the ICU safer, there's some danger in mistaking hope for reality. The answer to the question of what a simple checklist can achieve is, on its own, not much. So this is the final. So where do we go from here? What are my conclusions? Technical fixes alone, such as minimal checklists, do not work by themselves. They're simply reminder systems. They don't substitute for understanding how the plane flies. If the users don't have the understanding of how the plane flies or how science actually works, how to connect all the dots between question and design and data and conclusions, enforcing de minimis reporting requirements can require de maximis effort with de minimis results. And we've seen that over and over. Almost every person who's tried has seen this. Pressure and legitimacy needs to be exerted at all levels, from the funders, journals, regulators, and professional society. But change has to occur on the ground level, and it has to include education and the means to operationalize it. And again, we've heard a lot about that. Improving research practices must be driven by scientists reforming their own fields with the help of experts in rigor and reproducibility, impelled by institutional leadership, which is manifested by structures and metrics. Finally, I think we need to partner with and learn from those who study institutional and disciplinary change, that is, sociologists and organizational experts. And I'll end there. Thank you.
Great.